All right, let's jump right into it. Today, we are exploring the absolute bedrock of healthcare billing, evaluation and management coding. Now, if you're involved in medical coding, billing, or clinic administration, you already know that E/M codes are essentially the beating heart of your practice's revenue cycle. But in this explainer, we're going to break down the foundations and, more importantly, explore the massive paradigm shift that completely flipped the script back in 2023. If you're in the industry, the CPT code range 99202 to 99499 is probably burned into your brain, right? Mastering these specific numbers is literally the key to unlocking the entire E&M system. These aren't just, arbitrary digits. They represent the core of what a healthcare provider actually does when they're sitting in a room with a patient. And honestly, understanding how to accurately navigate this exact range, that is the difference between a compliant, thriving practice and one that is constantly sweating over audits or bleeding lost revenue. So here is our roadmap for today. 1. The core of E/M coding. 2. Why EM levels matter. 3. The 2023 guideline shift. And 4. Time versus MDM selection. Part 1. The core of E&M coding. Let's define what we're actually talking about here. E/M is a term that gets thrown around a lot, but its exact definition is super important. Basically, evaluation and management is the process of assigning codes to describe a patient encounter, but it's specifically based on cognitive services, complexity, and time. Think of it this way. These codes represent the intellectual work a provider does. It's the brain power. It's evaluating the symptoms, formulating a diagnosis, and managing a patient's care plan. It's kind of like the difference between being a medical detective versus a medical mechanic. Cognitive services, which are your E/M codes, are all about patient consultations, physical exams, and the heavy mental lifting of medical decision-making. On the flip side, procedural services are the physical actions, the surgeries, reading the x-rays, the diagnostic tests. EM is fundamentally about thinking, evaluating, and managing. Now, EM coding doesn't just happen in a vacuum. It spans a massive variety of healthcare settings. We're talking about everything from the emergency department in critical care units to nursing facilities and home health visits. But just to keep things focused today, we're going to put our lens primarily on the most common areas, which are office and outpatient services. Moving on to part 2, why EM levels matter. Seriously, why is accuracy so important here? Well, why do we bother going through this incredibly detailed and, let's be honest, sometimes really tedious scoring process for every single visit? It boils down to 4 vital pillars. First, appropriate reimbursement. Providers deserve to be paid accurately for the specific complexity and time they give a patient. Second, audit readiness. Good documentation acts as a shield for the practice. Third, fairness and compliance. It's a simple equation. Higher complexity equals a higher code level, which equals higher payment. And finally, it tracks the actual quality and workload of the provider. So, accurate coding isn't just about the money. It's about protecting the whole operation. To put the stakes into perspective, there's a well-known industry standard that says inaccurate or inappropriate E/M coding can lead to either underbilling or overbilling, which can result in audits, fines, and even legal action. And that hits the nail on the head. If you underbill, your practice leaks revenue and struggles to keep the lights on. But if you overbill, you are literally inviting severe federal and payer scrutiny. So getting this right, absolutely non-negotiable. Part 3. The 2023 guideline shift. The paradigm shift that changed everything. Everything we just talked about underwent a massive structural earthquake thanks to the AMA and CMS back in 2023. The before and after is like night and day. Pre-2023, you had to meticulously balance 3 components: history, examination, and medical decision-making. You literally had to count bullet points in a physical exam just to justify a billing code. It was exhausting. But the 2023 update radically simplified this. Now, for office and outpatient services, your level is based strictly on medical decision-making, or MDM, or total time spent. That's the whole shebang. Those tedious history and exam checklists no longer dictate your level. The goal of this update was so desperately needed. It was designed to reduce the crushing administrative burden on clinicians, encourage documentation that actually matters to the patient's care, and entirely eliminate that soul-sucking checkbox charting. Now, just to be crystal clear, taking a history and doing a physical exam are obviously still required to establish medical necessity. They just don't artificially inflate or deflate your E/M code level anymore. Part 4, time versus MDM selection. Let's look at how we actually apply this in the real world. So let's walk through these specific time thresholds for office visits. For an established patient, a 99212 requires 10 to 19 minutes. A 99214 requires 30 to 39 minutes. But here is the real game changer, the definition of time. Under the new guidelines, total time now includes both face-to-face time with the patient and non-face-to-face work done by the provider on the exact same date of service. So reviewing records before the patient even arrives or charting in the EHR after they leave, that all counts toward the total time now. Let's ground this with a quick scenario. Imagine patient A comes into the clinic for a routine follow-up from mild hypertension. The doctor reviews their blood pressure log, decides no medication adjustments are needed, and the total time spent for the whole encounter is 10 minutes. Because the medical decision-making is super straightforward and the time is brief, this results in a low E&M level, specifically a 99212. It's just your standard, low-complexity established patient visit. But now contrast that with patient B. This patient presents with new onset chest pain. The doctor does a full history and physical, orders an ECG and lab work, and has to consider a differential diagnosis, like is this angina or just GERD? The total time spent is 30 minutes. You can immediately see how the increased cognitive work, the higher risk factor, and the extra time instantly drive this up to a moderate to high EM level, which gives us a 99214. Which brings up a critical question. When do you choose to bill based on time versus medical decision-making? Generally, you want to use time when the provider spends a huge chunk of the visit counseling the patient, coordinating care, or reviewing a mountain of historical records. You want to use MDM when the encounter involves complex diagnostic decisions or moderate to high risk to the patient. But here is the golden rule. Write this down. If the documentation includes both time and MDM, you always select the higher supported level. Before we wrap up, if you want to make sure your coding is absolutely ironclad and audit-ready, keep these best practices in mind. Always verify that the history of present illness, review of systems, exam, and plan are actually clinically relevant to today's visit. Make sure the chief complaint is crystal clear on every single note. Align the provider's documentation directly with the MDM elements and the risk level. And honestly, most importantly, if key details about the duration, severity, or risk are just missing, query the provider, get that clarification. The beauty of the 2023 guidelines is that they finally let doctors be doctors again, rather than glorified data entry clerks. But I'll leave you with this provocative thought. As we fully embrace this shift toward cognitive-based billing, how will prioritizing medical decision-making over checklist charting fundamentally alter the way doctors interact with patients in the future? It is a fascinating evolution for healthcare, for sure. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.